Hello, everyone. I'm Dana Corson, a media officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us for a webinar on the report that was released last Friday, March 16th, titled The Safety and Quality of Abortion Care in the United States. As you may know, the report and supporting materials are available at www.nationalacademies.org/reproductive health. For those of you not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. The National Academies operate under a congressional charter to the National Academy of Sciences that was signed by President Lincoln in 1863. For each requested study, panel members are chosen for their expertise and experience and serve pro bono to carry out the study's statement of task. The committee members conduct the study and write the report independently of the sponsors. The reports that result from the study represent the consensus view of the committee and undergo external peer review before they are released, as did this report. I have with me several members of the committee to discuss the report's findings, but before I introduce them, I just want to go over a few technical reminders. After the opening remarks, we will begin to take questions through the Q&A box located in the right-hand corner of your screen. Simply type your question in the box at any time and click Submit. We ask that you leave the box set to send your questions to all panelists and that you identify yourself when asking a question. Please note we will be addressing questions only, not comments that come through. If you have any technical issues during this event, please contact WebEx Technical Support at 1-866-229-3239. And now I'd like to introduce the members of the committee who are here with us today. We have Dr. Ned Kalange, co-chair of the committee. He is Associate Professor of Family Medicine and Epidemiology in the School of Medicine and School of Public Health at the University of Colorado in Denver. Next, we have Dr. Helene Gale, the other co-chair of the committee, President and CEO of the Chicago Community Trust. Next, we have Dr. Carol Rowland Hogue, Professor of Epidemiology, and Jules and Uldine Terry, Chair of Maternal and Child Health at the Rollins School of Health at Emory University in Atlanta. Next, we have Dr. Jody Laurie, Associate Professor and Associate Dean for Global Affairs in the School of Nursing at University of Michigan in Ann Arbor. Next, we have Dr. Ava Pressman, Henry A. Feed, Professor of Obstetrics and Gynecology and Chair of the Department of Obstetrics and Gynecology at University of Rochester. Last but not least, we have Dr. Alina Salgonikoff, Vice President and Director of Women's Health Policy at the Kaiser Family Foundation in Menlo Park, California. We'll start off with a presentation summarizing the report, and then we will open it up for any questions you may have. Please note this webinar is scheduled to last 1 hour. And with that, I will turn it over to Dr. Gale.
Good morning. And as mentioned, we're going to do a brief overview, and I want to start with an introduction, talk about our approach to this report, and then I will hand it over to my colleague, Dr. Hogue, to talk about some of the trends and then other members of the committee. So first, the charge to the committee. These are the study sponsors noted here. We had 6 different sponsors for this study. The charge to the committee, So as was mentioned, This was a study that was done by the National Academy of Medicine, and the charge to the committee really was to build upon a report that was done over 40 years ago. In 1975, the Institute of Medicine issued a report, Legalized Abortion and the Public Health Report of a Study, and this was the last time that the Institute of Medicine did a comprehensive analysis of the scientific information related to abortions. And so our charge was to in fact look at the scientific evidence that has become available since that. As it says here, since 1975, there's been substantial changes in the U.S. healthcare delivery system and in medical science. And in addition, practices for abortion care have changed, including the introduction of new techniques and technologies. And so our study was a comprehensive look at the safety and quality of abortion services, and particularly looking at the literature since that time. We had 8 specific research questions that the committee considered. Number 1 was, what type of legal abortion services are available in the United States? What's the evidence regarding which services are appropriate under different clinical circumstances? 2, what is the evidence on the physical and mental health risks of these different abortion interventions? 3, what is the evidence on the safety and quality of medical and surgical abortion care? 4, what is the evidence on the minimal characteristics of clinical facilities necessary to effectively and safely provide the different types of abortion interventions? 5, what is the evidence on what clinical skills are necessary for health providers to safely perform the various components of abortion care? 6, what safeguards are necessary to manage medical emergencies arising from abortion interventions? 7, what is the evidence on the safe provision of pain management for abortion care? And 8, what are the research gaps associated with the provision of safe, high-quality care from pre to post-abortion? Given the charge that we had, we felt that the best way to look at these questions was to use the 6 dimensions of healthcare quality that had been developed by the Institute of Medicine. And so our analytic approach took these 6 dimensions into consideration. First, looking at safety, which is avoiding injury to patients from the care that is intended to help them. Effectiveness, providing services based on scientific knowledge to all who could benefit and refraining from providing services that are not likely to benefit. So being effective and avoiding overuse or underuse. 3, patient-centeredness, providing care that is respectful of and responsive to individual patient preferences, needs, values, and ensuring that patient values guide all clinical decisions. The 4th is timeliness, reducing waits and sometimes harmful delays for both those who receive and those who give care. Efficiency, avoiding waste, including waste of equipment, supplies, ideas, and energy. And last but not least, equity, providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and social economic status. So these were the 6 dimensions of health quality that we used as our analytic approach and analytic framework. The next slide, you will see our analytic framework, and without going into this in great detail, as you can see, we looked at all of these dimensions and used this as a way of evaluating the studies that related to these different aspects of the dimensions of health care quality. I will now turn it over to my colleague, Dr. Hogue, to talk about the trends. we also, this is how we actually conducted our research, looking at finding and assessing the evidence. We searched for peer-reviewed scientific research and clinical practice guidelines on contemporary U.S. abortion practices and health outcomes. We conducted systematic bibliographic search for evidence from all of those different sources, and we only included studies that met scientific standards using comparable study populations, controls for confounding variables, objective documentation of abortion history, and other methods to reduce the risk of bias. So we took a very, very comprehensive and rigorous approach using the best evidence and best available data. I believe we looked at over 10,000 peer-reviewed articles. So I will now turn it over to my colleague, Dr. Hoag, to talk about some of the trends that we found in looking at in doing the study.
Thank you, Dr. Gale. The committee examined trends in abortion to add context to our work. We found that since 1980, the abortion rate, which is the number of abortions per 1,000 women ages 15 to 44, has fallen from 29 to nearly 15 per 1,000 by 2014, and that the total number of abortions is declining, reaching a low of just 926,000 in 2014, the latest year for which we have data from the two data sources that provide this information. The decline has been attributed to historic decline in unintended pregnancies and increasing use of contraception, as well as restrictions affecting access. We also found, in the next slide you will see, that the vast majority of abortions are performed early in pregnancy. In 2014, half were done by 7 weeks of gestation measured from the last menstrual period, 90% by 12 weeks of gestation, and that medication abortions were 45% of abortions less than 9 weeks of gestation and are likely to increase in number and proportion in the future. Next slide, please. Thanks. Women who have abortions are disproportionately lower income. 3/4 of them are either in families that have incomes below the federal poverty level or between 100 and 200% of the federal poverty level. They are disproportionately women of color. 3/5 of them are either Black, Hispanic, Asian Pacific Islander, multiracial, or other women of color. Most are young, nearly 3/4 are under 30, and 86% are unmarried. We also found that a substantial proportion, 17% of women, have to travel more than 50 miles to obtain an abortion. Now I'd like to turn this over to Dr. Eva Pressman, who will talk about the contemporary U.S. abortion care.
Thank you, Carol. Next slide, please. So we divided abortions into 4 different methods, and I will briefly discuss each of those methods, what's involved, and some of the findings. The first method of abortion that we looked at was medication abortion. This is using a medication called mifepristone, which is the only medication specifically approved for medication abortions. It is FDA approved up till 10 weeks of gestation using a dose of 200 milligrams followed by 800 micrograms of misoprostol 24 to 48 hours later. The distribution of mifepristone is restricted to certified prescriber through a program called REMS, which regulates who and how it can be prescribed. Overall, 22% of abortions are done through medication abortion as of 2013. 45% of abortions before 9 weeks are medication abortion. And as we said previously, this is likely to increase over time. Although the mifepristone is administered in a clinic, the abortion itself occurs after the patient goes home. And this is really important when looking at the facilities necessary. Next slide, please. Aspiration abortion is the most common method used, currently accounting for about 68% of all abortions. It can be performed up to 14 to 16 weeks of gestation and is a pretty minimally invasive, short procedure. It's also a common gynecologic procedure that's used for management of miscarriage or irregular uterine bleeding. Next slide, please. Dilatation and evacuation, or D&E, is a much smaller proportion of abortions. Fewer than 9% of abortions are performed after 13 weeks as of 2013, and most of these later procedures are D&Es. D&E is generally used when the aspiration method is not appropriate, and it is the preferred method for later abortions because it has fewer complications, takes less time, is associated with less pain and less expense than the last method, which we'll discuss, which is induction. D&E is, however, banned in 2 states, and there's limited access in other places due to limited access to training. Next slide, please. Induction abortions are pretty rare. They involve essentially the induction of labor. It is less than 2% of abortions at 14 weeks of gestation or later, which is equivalent to less than 0.02% of all abortions. Next slide, please. The committee also looked at the effect of comorbidities and maternal medical history on abortion safety. We found that obesity is not a risk factor for women who undergo medication abortion or aspiration abortion for complications or long-term problems. The research on obesity and complications during a D&E abortion is less certain, mostly because these are more rare procedures and less data is available. This is particularly true for obese patients with a BMI of 40 or greater after 14 weeks gestation. A history of a prior C-section is not a risk factor for complication in medication abortions, aspiration abortions, or inductions, but women with multiple cesarean deliveries may be at risk for complications during D&E abortions. Next slide, please. We'll talk a little bit about pain management in the next section. Next slide. So for medication abortion, nonsteroidal anti-inflammatory drugs are used to reduce the discomfort of pain and cramping. However, most women still experience high levels of pain. Pain management for the other abortions range from local anesthesia to minimal, moderate, or deep sedation, and most rarely general anesthesia. Moderate sedation does require nurses or other qualified staff to monitor the patient in addition to the clinician performing the abortion, while deep sedation or general anesthesia requires the expertise of an anesthesiologist or certified registered nurse anesthetist. And those things are important when we talk later about the clinical settings. Next slide. So next I will introduce Dr. Alina Solganikoff to talk about the clinical settings.
Great, thank you. I want to now present some of the committee's findings relating to clinical settings for abortion services. First of all, we find that the vast majority of abortions, that's 95%, are currently performed in office-based non-hospital settings, but the number of those facilities are falling, most notably in states with many abortion-specific regulations. We find that the availability of abortion services is limited in the United States for many women. 40% of reproductive age women live in a county that doesn't have an abortion provider, and in 25 states there are 5 or fewer abortion clinics, and in 5 states there's only 1 clinic. Next slide, please. We also found that most abortions can safely be provided in office-based settings. For medication abortion, we found that no special equipment or emergency arrangements are required as the abortion occurs after the woman leaves the clinical facility. As Dr. Pressman mentioned, typically at home. For aspiration, D&E, and induction abortions, the minimum facility characteristics, the level of sedation really should determine the safeguards. When moderate sedation is used, the provider should have emergency resuscitation equipment, an emergency transfer plan, and equipment to monitor oxygen saturation, heart rate, and blood pressure. The use of deep sedation has the same requirements with the addition of equipment to provide general anesthesia and monitor ventilation. Next slide, please. The committee concluded that the facility should have the appropriate equipment, personnel, and emergency transfer plan to address complications that might occur. Many of these safeguards, again, should be determined by the level of sedation. Providers should be able to arrange for patient access or be transferred to facilities that are equipped to provide emergency intervention if necessary. The committee finds that clinicians that perform abortions do not require hospital privileges to ensure safe outcomes for the patient. I'm going to now turn it back to Dr. Eva Pressman to discuss our conclusions on the clinical skills and training.
Thanks, Dr. Slivyanikoff. So next slide, please. So the committee evaluated all the data that was available to establish the required clinical competency and basically found that abortion care, like really all other medical care, requires clinicians to be able to prepare patients and do a clinical assessment. Because of the pain associated with abortion, pain management was required. It was necessary to identify and manage the side effects and serious complications. And we also found that there was great importance and improved outcomes with contraceptive counseling and provision. Looking at medication abortions, the providers can be physicians, nurse practitioners, physician assistants, and certified nurse midwives. When you move to aspiration abortions, the required skills include the technical aspects of the aspiration procedure, and so that trained physicians, nurse practitioners, and physician assistants and certified nurse midwives with appropriate training could all perform these procedures. D&Es require more surgical expertise and sufficient caseload to maintain surgical skills, and the providers generally included OBGYNs, family medicine physicians, and other physicians with appropriate training and expertise. For induction, the skills required were really those for managing labor and delivery, and those providers usually included OBGYNs, family medicine physicians, and certified nurse midwives. Next slide, please. The committee evaluated the availability of providers, and this was really quite varied. The safety and quality of abortion is really contingent on the availability of skilled providers, and this is influenced by many factors. The declining number of abortion facilities, the geographic maldistribution of providers, and the legal restrictions on training and provision all impact availability of providers. Access to clinical education and training in abortion care is also highly variable in the United States. Some residents and trainees must seek out abortion training and experience outside of their educational program, which provided another barrier. Training opportunities are particularly limited in the southern and midwestern states and in rural areas really throughout the country. Next slide, please. This map sort of depicts where training facilities, residencies, and fellowships offer abortion training in the United States, and you can see there's a concentration of programs along the northeast and west coast, with much fewer in the middle of the country. Next slide, please. I'll now turn this over to Dr. Carol Hogue to talk about long-term health effects.
Thank you, Dr. Pressman. The committee reviewed research covering tens of thousands of women who had documented abortions and had been followed after abortion in rigorous observational epidemiologic studies. All studies used comparison groups that minimized known biases in this type of research. The studies also were of the abortion methods currently in use in the United States. Next slide, please. The committee found that having an abortion does not increase a woman's risk of secondary infertility, pregnancy-related hypertensive disorders, abnormal placentation after a D&E abortion, or preterm birth, that is less than 37 completed weeks of gestation. The committee found that although rare, the risk of very preterm birth, that is less than 28 weeks gestation, in a woman's first birth is associated with a number of prior abortions. With no abortion in this study, very preterm birth was 0.3%. With one prior abortion, although not statistically significant, it was 0.4%. With two prior abortions, 0.6%. And with three or more prior abortions, 1.1%. The details of this study can be found in the report in table 4.2, which is on pages 414 and 415. With respect to, next slide please, long-term physical health effects having an abortion does not increase a woman's risk of breast cancer. Next slide, please. And having an abortion does not increase a woman's risk of depression, anxiety, or post-traumatic stress disorder. Next slide, please. Now Dr. Salganikoff will talk about state regulation.
Thank you. In addition to federal and state and local rules and policies that govern all medical services, there are numerous abortion-specific laws and regulations that affect the delivery of abortion care, making it among the most regulated medical services in the country. Abortion-specific regulation range from those that specify the clinical qualifications of abortion providers, the types of procedures that they are permitted to perform, the requirement for unnecessary services like those that require all women seeking abortions to have sonograms or receive in-person counseling, mandate waiting periods, in some states up to 72 hours. Many states have detailed facility standards for abortion services that can define the type of facility and even specify room size, corridor width, or the distance from the hospital. Other policies prevent facilities that receive state funds from providing abortion services or place restrictions on the availability of services based on the gestation of the fetus. Many of the states define limitations on the circumstances in which private health insurance and Medicaid can be used to pay for abortions, limiting coverage only to pregnancies resulting from rape, incest, or posing a medical threat to the pregnant woman's life. And finally, some states have laws and policies that require abortion providers to have hospital admitting privileges or a specific agreement with a local hospital. I'm now going to turn it over to our committee co-chair, Dr. Ned Kalange, to discuss our findings on abortion quality.
Thanks, Dr. Salganikoff, and good morning, everyone. I'd like to return to the 6 dimensions of quality health care and just summarize the events within those different criteria. So when we look at the criteria of safety, we find that legal abortions in the United States are safe, whether by medication, aspiration, D&E, or induction. Serious complications are rare. In most studies, complications occurred in less than 1% of abortions and did not exceed 5% in any of the rigorous studies. Safety is enhanced when the abortion is performed as early in pregnancy as possible, and current pain management methods are safe when appropriate precautions are followed. I would just add that thinking about long-term safety, just to reiterate the findings that abortion does not lead to an increased risk of breast cancer, does not increase risk of mental health issues, and does not affect future fertility. Next slide. In terms of effectiveness, we found that legal abortions in the United States are effective. As we look, though, at the issue about providing those to all who could benefit, we found that whether women receive the abortion care that best meets their needs depends on where they live. In many states, because abortion regulations can prohibit abortion care in safe and clinically appropriate settings, such as doctor offices and clinics, they can prohibit qualified clinicians, including family medicine physicians, certified nurse midwives, nurse practitioners, and physician's assistants from performing abortions. They could require the informed consent process to include inaccurate information on abortion's long-term physical and mental health effects. They could require clinically unnecessary services and delays, such as pre-abortion ultrasound, in-person counseling, and waiting periods. They could require clinicians to have hospital privileges, and they could overrule women's and clinicians' medical decisions. As the committee looked at these list of potential restrictions, found no evidence that they improved the safety and quality of care. Next slide. In terms of patient-centeredness, we found that patients' personal circumstances and individual preferences, including the preferred abortion method, and the patient's needs and values may be disregarded depending on where they live. Their decisions are impeded if they are required to receive inaccurate or misleading information on abortion's potential harms, and they're impeded if clinically unnecessary services and delays, again, such as pre-abortion ultrasound, in-person counseling, and waiting periods, actually change their decisions. Next slide. In terms of timeliness, we found that this depends on a variety of local factors, such as the availability of care, affordability, the distance from the provider, state requirements for an in-person counseling appointment, and waiting periods. We found that waiting periods may actually delay the abortion beyond the actual mandatory waiting period because of the logistical challenges of arranging and getting to a second appointment. And we know from the rest of the study that delays put the patient at greater risk of an adverse event. Next slide. In terms of efficiency, regulations that require medically unnecessary equipment, services, or additional patient visits will increase the cost and decrease the efficiency of abortion care. Next slide. Finally, in equity, we determined that lack of insurance coverage, waiting periods, limits on qualified providers, and requirements for multiple appointments are more burdensome for women who reside far from providers or have limited resources. Next slide. The committee was charged with looking at research gaps. Next slide. We found no identified gaps in research that raised concerns about the safety and quality of abortion care. However, we did generate a list of questions we felt that merited further investigation, such as, how do the FDA restrictions on mifepristone distribution affect the quality of care? Can the pain of medication abortions be managed prophylactically? What is the best approach to managing pain during aspiration procedures without sedation? Can advanced clinical providers, such as nurse practitioners, certified nurse midwives, and physician's assistants, be trained to perform D&Es safely and effectively? And finally, do lower income women receive the support services they need, and what are the best practices for providing these social support services? With that, I'd like to turn things back over to my co-chair, Dr. Gale, to wrap things up. Helene?
Great, thanks. And I think thanks to everybody for a very comprehensive overview. I hope this has been a good opportunity to understand our report. And I think with that, I will open it up for questions.
This is Dana again. Thanks, everyone, for that presentation. So we're starting to get some questions coming in. Please type them in the lower right-hand corner of your screen. To start us off, so how have abortion care services changed since national legalization in 1973? I think, Eva, that might be one for you.
Sure. So abortion care, just like all of medical care, has evolved quite a lot over the last 40 years. I think the biggest innovations have been the availability of medication abortions, which essentially takes the procedure part out of abortion, and the techniques that we use for really all of the other forms of abortion have also evolved quite a bit over the last 40 years.
And I guess I would just add to that I think, what we tried to also convey is that if you think about care in a comprehensive way, that a lot of the regulations that have also been part of the landscape of abortion care over the last several decades have also impacted particularly the quality of care provided to women. So I think the comprehensive picture of how things have evolved include both the clinical care, but also what has been the environment in which the care is given, and what are some of the ways in which the quality has been impacted by the regulations that have been put in place.
Thank you. Next question. Of the reasons attributed to a reduction in abortions, is there a trend which has been the most prominent in the reduction?
Carol, I don't know if you want to.
Yeah, I think the biggest trend is in the reduction of clinics that provide abortion. There's been quite a drop-off in recent years. The other, I think, is the reduction in unintended pregnancies, probably associated with the uptick of long-acting reversible contraception, such as implants and intrauterine devices, which have cut down on unintended pregnancies dramatically.
And just to also add, you know, the scope of our study did not specifically look at the reasons, all of the reasons for those trends. So we did not look at that in great detail to be able to answer the why, but we were able to definitely show that there has been a real decline. But I think the comments that Dr. Hogue made are very much in keeping with our general knowledge of what are some of the influences.
Thank you. Next question is, controlled substances like opioids or tramadol are also often used for medication abortion. Did you find any data on the current prevalence of narcotics for medication abortion?
This is Eva. We didn't look at that specifically. What we did find was that the most common pain medication treatment for medication abortions was nonsteroidal anti-inflammatories, not narcotics.
And I would just iterate that was one of our questions around optimal pain management, or what other options might be safe and available specifically for medication abortions.
Next question is, any thoughts on the use of antibiotics with medication abortion? Some find this to be inefficient and increasing risk due to unnecessary antibiotic use. Was this evaluated?
This is Eva again. We did look at the risk of infectious complications and the use of antibiotics in some of the data we examined. Currently, the route of administration seems to play a bigger role than the addition of antibiotics, and so antibiotics are not generally recommended for medication abortions.
Thank you. Next question, how does the U.S. fare in providing proper education and training in abortion care?
This is Jody. I can take that question. I think the committee found that access to clinical education and training in abortion care in the U.S. is highly variable at both graduate and undergraduate levels, and that training is particularly limited in southern and midwestern states as well as in rural areas throughout the country.
Thank you. Next question, which states have the most restrictive abortion laws today?
This is Alina Salganikoff. I can take that on. We didn't look specifically and count all of the restrictive laws, but we did find that the states that are in the south and in the center of the country are those that have the most numbers of abortion-specific regulations.
Thank you. Next question. Can anyone speak to the rates of teen pregnancy and abortion, as well as for women over the age of 45? Are there any trends for those two age groups?
Carol?
Yes, I'd be happy to take that trend. The women over 45, I don't have that information. 35 and over, about 12% of the abortions are for women 35 and over currently. And of abortions, only about 11% are to teens, and most of those are 18, 19-year-olds. About less than 4% are to 15 to 17-year-olds or younger women. The vast majority of abortions are to women in their 20s.
Thank you. And what data do you have on fatality rates for the different methods?
This is Carol again. Abortion is extremely safe, and there are virtually no deaths associated with abortion. The we compared abortion fatality to other commonly used procedures, and I am looking for the table that can point you to that.
It's 2.4 in page 224 of the report.
Thank you. One of the things that some people are concerned about is whether once a woman becomes pregnant, is she more likely to suffer a major problem which could lead to death. And basically, the risk of death does increase, but even though it's very, very small, as gestation increases, such that for the abortions of 20 weeks or greater gestation, the mortality rate is not as high as for childbirth, but still higher than it is in earlier gestations. For earlier gestations, the mortality rate is less than 1/10 of what it is for women who carry their pregnancies to delivery.
And just to remind people, you know, what we studied were legal abortions, so abortions that are very, very safe, as everybody mentioned, under the right clinical and other circumstances. Clearly, we know that abortions that are not performed legally and don't have the right provisions could, in fact, have higher mortality rates. But what we studied, what we looked at in our study were legal abortions that we found that the safety was very, very high, as is mentioned.
Thank you for that. The data, the most recent data you're using in the report is from 2013. Why did you stop at 2013?
So this is Carol again. The information that we have available to us is provided through the U.S. Centers for Disease Control and Prevention and also the Guttmacher Institute. They independently have data sources, and then they also combine those data sources for a lot of the data that we have available to us. Those entities have not released information on abortions since 2013. The Guttmacher Institute did have a survey in 2014 that we relied on, but these are the latest data that we have available to us.
Thank you for that. Did your research track the effect of abortion on women 5, 10, 15, 20 or more years after their abortion, including those who may have had an abortion in the 70s, 80s, or 90s? This includes any physical, psychological effects after abortion.
Long-term effects.
I'm sorry. There seems to be an echo.
Do you want me to repeat the question?
I heard the question, but I'm hearing an echo of my response.
Okay, we're not. So I think if you can keep going, or if someone else can handle that question, that would be great.
I'll try. This is Carol again. There's an ongoing study in the U.S. Called the Turnaway Study, which is looking at mental health effects, and that study has followed women and reported on a follow-up up through 5 years post-abortion. The studies of breast cancer usually cover decades, and the studies of pregnancies usually cover less time because these are comparing abortion generally in the first pregnancy with childbirth in the first pregnancy, so they are short term. We did also look at long-term mortality studies because some have raised the question of whether abortion leads to mortality at later ages, but we found that the scientific rigor of all of those studies was too poor to make any assessment of that.
Thank you. Next question. It sounds like you are saying that there is no scientific basis for the abortion-specific regulations such as waiting periods, mandatory counseling, facility requirements, etc. Would that be an accurate characterization?
Yeah, I think we overall found that the regulations did not improve safety and had an impact on the 6 dimensions of quality. So we did not find evidence that suggested that the regulations improve safety or improve quality, and in fact had a impact on the quality dimensions that in all 6 of those did not show a positive impact on the dimensions of quality.
Yeah, this is Ned again. I would say, in addition to that, as you looked at the different restrictions, not only was there not evidence of improving any of the dimensions of quality, there was some evidence that they diminished quality, and overall, as you thought about the impact on the other dimensions, we would expect many of them diminish the overall quality of care.
Thank you. Next question. Can you talk about the strength of the evidence for the finding of preterm birth risk with multiple abortions?
Yes, this comes from one study of women who were delivering their first birth after no abortions, 1 abortion, 2 abortions, or 3 or more abortions. It's a study out of Finland, and Finland has similar abortion rates and somewhat similar restrictions on the gestational age of abortion as the U.S. We only looked at studies outside of the U.S. that were comparable enough to what happens in the U.S. to make any kind of conclusions. And in fact, it's impossible with record linkage, which is required for this kind of information, to do this kind of study exclusively in U.S. So this study in Finland was of nearly 40,000 women who had abortions. 3/4 of them had had only 1 abortion before their birth. About 12% had had 2 abortions, and about 2.5% had had 3 or more. So not only did the study of very preterm birth show only a slight increase of a very rare occurrence, but also this was of a minority, a small minority of women who had abortion before their first birth.
Thank you. Next question. The report says that abortions are safe in office-based settings. What kinds of offices? Does that include typical doctor's offices?
This is Eva. Really, it seemed for medication abortions, the site of the administration and the site of the actual abortion are separate, so any medical office would be fine. For anything that requires sedation, the office needs to be equipped to handle the possible complications of sedation. In the absence of the use of sedation, any doctor's office would be fine.
Thank you. Next question. Did any of the studies you looked at discuss abortion reversal medications?
This is Eva again. We looked at a very small number of studies that looked at reversal medications for medication abortion. Really, they're not studies, but case reports. The data is really inconclusive, and reversal of medication abortion is not something that is recommended at this time.
Thank you. Did you consider the question of whether medication abortion can be managed by the patient without a trained provider? Would you consider that to be an appropriate area for future research?
This is Eva. I can take that one as well.
Oh, okay.
Or Carol, go ahead.
Oh, go ahead.
So we didn't specifically look at that. There are some studies in other countries of telemedicine prescription for medication abortions, but given the risks of medication abortion, the control of the dispensing does not seem warranted at this time.
And I was just going to mention that one of our research gaps was to look at how the FDA restrictions for medication abortion distribution affected the quality of care. So we think it's an area where there should be some research, but as mentioned, given the safety of it, there's no clear reason why, in fact, it could not be dispensed in other ways more directly.
Just to add that right now the mifepristone is only available directly from the manufacturer. Women cannot get mifepristone from a retail pharmacy directly.
Thank you. Next question is, do you have any information about the gestational history of women who receive abortion care? Is it their first pregnancy?
We do have data on the number of previous number of previous pregnancies, and let me flip to that. I'm just looking for the table, and I'm going to point you to that table. It is Table 1.2 on page 1.14. 29% had no prior pregnancies, and 26% had only prior births, not any previous abortions. So we don't know how many women are in their, and I'm sorry, about 12% had only prior abortions. But we don't know, we can't break that down any further because these are the data that are provided by the sources that I mentioned previously. With prior birth, 41% had had no prior birth before their abortion.
Thank you. Can you talk a little more about the FDA REMS program to distribute mifepristone?
Alina or
Hello,
Eva?
this is Alina. I can take that.
Yeah. Mm-hmm.
The FDA has a program called the Risk Evaluation and Mitigation Strategy Program, specifically for Mefeprex, which is the brand name for mifepristone. And so the FDA basically considers the following when they're determining the necessity of a REMS, and this looks at the size of the population, the seriousness of the disease or condition that's expected to be treated with the drug, the expected benefit of the drug, the duration of the treatment, and the seriousness of any potential adverse events, as well as whether it's a new molecular entity. There are 77 approved REMS programs, but what we found is that there are drugs that have far fewer risks that don't require the REMS, and so we recommended that this be looked at in further research. There were restrictions when the mifepristone was first approved in 2000, but the REMS program was established in 2011 and recently revised in March 2016, along with an update to the drug's label.
This came up a little bit, but can you expand on any evidence concerning the use of telemedicine for the provision of medication abortion?
So currently that is not an option in the United States. It has been looked at in other countries and has been found to be quite successful.
I know that there are currently studies underway that are looking at this as a feasibility, but we didn't look at those in this particular study.
Thank you. Next question, what data did you use to conclude that there are no psychological or emotional effects of abortion, and how long did that report follow the women?
This is Carol. We looked at all of the studies that had been published in various reviews of the literature, as well as studies that have been published since reviews of the literature were published. And we found that most of the published research on mental health outcomes is limited by biases that really lead to potentially misleading information. And we did identify 7 systematic reviews that we then looked at the individual information from those reviews. And in addition to the more recent studies, we identified using rigorous criteria, a few studies, plus the more recent study of the Turnaway study. Most of these are in the U.S. or in Northern European and Western European countries. And some of them go for some years. The Finnish registry data goes out several years, for example. The Turnaway study is the most rigorous study that has been published from the United States. And it is of women who had abortions close to the deadline of the gestational age that a clinic will allow, women who had abortions early in gestation, and women who were turned away from abortion because they came to the clinic beyond the gestational age that the clinic was comfortable in providing abortions. They have been followed for a number of years, and publications regarding them, this study, are of 5 years, and they are continuing to be studied. But the 5 years post-abortion is the longest that study has published data.
Thank you, and we have time for one more question. Kind of to wrap us up, can you tell us a bit more about the areas that you found merit further investigation?
I'll maybe say something overall, and then others might want to chime in. I think, as we said, we didn't identify any gaps that we in research that raised concerns about safety and quality, and so our suggestions were for things that would perhaps continue to evolve and enhance what is already a very, very safe procedure. So we didn't find things that we thought were glaring gaps in terms of the ability to provide abortion care safely. But we did think, and as many questions have come up, that are questions around the FDA restrictions on medication abortion, on mifepristone distribution. So, as several questions have pointed to, I think we thought that was an area that there was room for looking at, were these restrictions necessary? Did they affect the quality of care? Were there different ways of doing it, et cetera? Questions touched on the issue of pain medication. Again, while we think that under most circumstances pain was managed well and that was not a major issue, there are always ways in which making this as pain-free intervention as possible is always something that could be evolved. So we looked at that whole area of pain and pain management. There are also, in the provision of care, particularly many of the regulations stipulate care being provided primarily by physicians, but we looked at a range of studies that showed that a wider range of clinicians, nurse practitioners, physicians assistants, et cetera, could be trained to perform D&E safely and effectively, and therefore making them more available. So we wanted to see if one of the questions was, could advanced clinical practitioners be able to perform D&E safely and effectively? And then I think the issue of equity and how lower income women, since lower income women disproportionately access abortion services, are there the appropriate social services available, and are there best practices about what social supports are necessary for poor women who seek abortion care? So that's kind of, again, looking at the framework that we looked at, why we thought these were some of the areas that merited further investigation. And I don't know if others want to add anything to any of those.
Okay, this is Dana. If nothing else, oh, go ahead, Helene.
No, I was going to say the same thing you're about to say. If not, then I think we want to thank people for your participation.
Yes, thanks everyone for tuning in today. That's all the time we have for questions. Once you exit this webinar, you will be redirected to our report page at www.nationalacademies.org/reproductive health. And a few of you have asked about this. The slides from today's webinar and the recording will be available on that page next week. And with that, again, I'd like to thank all of our speakers and thank you all for tuning in. Have a great day.